Hi everybody, this is Dr. Chitra, your mentor at StudyMEDIC and StudyMRCOG. And StudyMEDIC is back to your rescue again, especially those of you who are planning to appear for MRCOG Part 1 in January 2025. So we are back with our RRR series, and today I'm going to talk to you about the anatomy module. So before we begin, this is just a rough distribution of the various modules that you have for your Part 1 exam. And if you see, anatomy is a very big chunk of paper 1. So it forms at least around 25% of Part 1 of paper 1. So expect something around 20 to 25 questions from anatomy. And the thing about anatomy is that it is a knowledge-based area. Very few questions you could solve by applying logic or trying to make a wild guess. So anatomy is one subject that you have to be very thoroughly prepared. Okay. Agenda for today's video is to be able to solve SBAs related to anatomy module. So let us begin. Here goes the first question. Okay. A typical question would be like this, that you would be given a scenario, and of course it's a distractor to you, and then the main question would be at the end. But try to read the scenario so that it gives you some information of the type of question that is there. So here you have a young girl who has presented to the A&E with a painful swelling on her private parts. She has been having this swelling for the past few months. Recently, she has noticed an increase in the size, and also it has become tender. So you have examined her with the help of your consultant, and your consultant has come to the diagnosis that this is a Bartholin's gland, or it is a Bartholin's cyst with an abscess, and he has asked you to drain the abscess. Now the question is, this part 1, the ST1 that is there with the consultant doesn't know about the surgical anatomy and wants to know where the Bartholin's gland is situated. Options here are, you have the deep perineal pouch, superficial perineal pouch, ischiorectal fossa, pudendal canal, or the urogenital diaphragm. Now we know urogenital diaphragm is basically, it is a muscular structure, so it is not going to have any gland or a cyst. Coming to the pudendal canal is a very small canal that is located, and it is there in the somewhere in the posterior part of the ischiorectal fossa, and it doesn't contain any glands or any cysts. It only contains the internal pudendal artery, nerve and vein. So pudendal canal is out of question, even ischiorectal fossa, because we know ischiorectal fossa mainly contains fat and a few lymph glands. The options that you are left with are the deep perineal pouch and the superficial perineal pouch. Now here you have to know the contents of the superficial and the deep perineal pouch if you were to answer this question. So let us see what are the contents. The answer is superficial perineal pouch, because the other contents that are there in the superficial perineal pouch, you have the superficial transverse and deep superficial perineal muscles. Then you have the other muscles like the bulbospongiosus, ischiocavernosus and the crura of the clitoris. In the deep perineal pouch, you have the deep transverse perineal muscles, another important structure, that is the external urethral sphincter and the bulbourethral glands. This question is a hot favorite of the college, and you have to know the contents of the superficial and deep perineal pouch. Stop the video here, have a look at what are the contents of the superficial and the deep perineal pouch, because either of the questions would be asked about contents of the deep perineal pouch or the superficial perineal pouch. Another typical question would be, which artery is liable to damage during an appendicectomy done through McBurney's incision? Options here are iliolumbar artery, superficial circumflex iliac artery, deep circumflex iliac artery, superior luteal or inferior epigastric artery. You should have at least a rough idea about where is McBurney's incision and what are the arteries that are going to come in contact there, or the arteries that are likely to be near McBurney's point. So iliolumbar, we know it is an artery that is there in the posterior abdominal wall. So that is not going to come in your McBurney's incision. Regarding superior gluteal, it is present above the umbilicus, so that is also not likely to be injured. Inferior epigastric, yes, it could be, but remember, inferior epigastric is an artery which is more nearer to the midline than the superficial or the deep circumflex iliac artery. So you have two choices here. You have to choose either between superficial iliac or the deep circumflex iliac. Let us have a look at McBurney's incision. Okay, so McBurney's incision is an incision which is more lateral. And here you have either the deep circumflex iliac or the superficial circumflex iliac. Now, superficial circumflex iliac is another artery. If you have a look here, that artery is more towards the medial side. Okay, so that is why it is unlikely to be present, or it is unlikely to be damaged during an incision taken for appendicectomy. So it is the deep circumflex iliac that is injured at the level of the anterior superior iliac spine. The deep circumflex iliac gives off an ascending branch, and it is this ascending branch that is likely to be injured. Okay. Now coming to the next question. Which of the following nerve pierces the internal oblique muscle and passes through the inguinal canal? So we know that muscles of the lumbar plexus, that is the femoral or the obturator, then you have the genital branch of the genitofemoral artery, ilioinguinal or iliohypogastric. All these are the branches that they go and supply even the lower part of the abdominal wall or the genitals or the lower limbs. So remember, femoral nerve, it doesn't pass through the inguinal canal. It passes below the inguinal ligament. Similarly, genital branch of the genitofemoral artery, it doesn't traverse through the inguinal canal. Even the lateral cutaneous nerve, it is somewhat which is more lateral. So you have two choices. You have either ilioinguinal or you have iliohypogastric. So out of these two, it is the ilioinguinal which traverses through the inguinal canal. Okay, the iliohypogastric, it doesn't pass through the inguinal canal. It pierces the inguinal canal but supplies down. Whereas the ilioinguinal, it enters the inguinal canal, it traverses through the inguinal canal, and then it exits through the superficial inguinal ring, and then it gives off its terminal branches, and then they supply the genital area. Okay, so remember that it is the ilioinguinal nerve that traverses through the inguinal canal. The other nerves, they do not traverse. The iliohypogastric, it only pierces but it does not traverse. That means it does not enter through the deep inguinal ring, and it does not exit the inguinal canal through the superficial inguinal ring. Questions about labor analgesia are also something which is asked very frequently. So you have this primigravida who is in labor. She has requested for an epidural analgesic because she wants to enjoy painless labor. So the question asked is, which is the lowest level? Like you see the anesthetists and they are talking about, okay, I will go one level up or I will go one level lower. So which is the lowest level, or which is the lowest spinal space that the anesthetist has to block so that this woman, she can enjoy painless labor? So the choices are T10, T11, T12, L1 or L2. For this, you have to know what is the nerve supply to the uterus. The answer here is L1, because supply to the uterus comes from T10 to L1. Now here you have to understand that if the segment T10 is blocked, or even T11 is blocked or T12 is blocked, what happens is once the drug is given by the anesthetist, it will travel lower down, and so even L1 is going to get blocked. But if the anesthetist gives the block below L1, so supposing he chooses the space of L2, what happens is the drug is not going to travel upwards. It will travel downwards, and labor pain is felt through segments T10 to L1. So even if the lowest segment L1 is blocked, the woman can enjoy painless labor, whereas if a segment lower than L1 is blocked, then she will still continue to experience labor pain. Something about the fetal skull. So where is the coronal suture located? For this, you can envision the fetal skull in front of you. Now you know there are two planes, sagittal plane and the coronal plane. So sagittal plane is the one that will divide the body into anterior and posterior parts. Okay, whereas coronal, it is going to divide it into right and left parts. So you can envision the fetal skull in front of you. Imagine which are the bones that are there in the fetal skull. So you have temporal bone, you have parietal bone, you have frontal bone, and you have occipital bone. So once you have that picture of you in front of you, then you can guess where is going to be the coronal suture. Okay, so here you have the coronal suture that is there in between the frontal and the parietal bones. Okay, whereas you have the sagittal suture that is there, which is between the two parietal bones. So here remember that the sagittal suture, it is there in between the two parietal bones, and you have the coronal suture which is more anteriorly. It is present in between the frontal bones and the parietal bones, and then you have another frontal suture which is there in between the two frontal bones, and posteriorly then you have the lambdoid suture which is there in between the parietal bones and the occipital bone. Okay. After a vaginal hysterectomy, you have a woman who has come back to the clinic and she says that she has some sensory loss over the medial part of her thigh. So she has no other symptoms. It is only a sensory loss. So the consultant, he examines her and then he tells her that yes, there is damage to a nerve, and this damage has probably been there because she was not given the proper lithotomy position, and the nerve that has been damaged, this nerve is the nerve that passes below the inguinal ligament medial to the anterior superior iliac spine. So he is asking you which is this nerve that is likely to be damaged. The options are femoral nerve, genitofemoral, ilioinguinal, anterior iliac, or lateral cutaneous nerve of thigh. Okay. So the genitofemoral, it is not something that it is, yes, it is a sensory nerve, but it will not give rise to sensory loss over medial part of the thigh, and it is not a nerve that passes medial to the anterior superior iliac spine. Femoral nerve, we know it passes below the inguinal ligament, so it is not really related to the inguinal canal. And femoral nerve, if you see in this picture, it passes more medially. It is the lateral cutaneous nerve of thigh that passes below the inguinal ligament, just medial to the anterior superior iliac spine. Okay. Another frequently asked question is about the last pair branches of the aorta. We know these are the common iliac arteries. These common iliac arteries, they divide into the internal and external iliac arteries at which vertebral level? be very careful when you're reading this question. They are not asking you where the aorta divides. They are asking you at what level the common iliacs they divide into internal and external iliac. Okay, so you know the aorta, it divides into the common iliacs at around the level of L1 or L4, sorry, not L1, L4. Then the common iliacs run for about 2.5 to 3 centimeters, and then they divide into the internal and external iliac arteries. So if the aorta is dividing at the level of L2, then the common iliacs should divide at a lower level. They normally divide at the level of L1 into an internal and external iliac arteries. So be very careful about whether they are asking you the level at which the aorta divides or the level at which the common iliacs divide. If they are asking about bifurcation of the aorta, it is at the level of L4, but the level at which the common iliacs divide is S1. Okay. Another very frequently asked question is about the boundaries of the ischiorectal fossa. You have to be very thorough with the boundaries. So here they are asking you which of the statements is correct. So just pause the video here for a minute. Read the options very carefully because they are all about the boundaries of the ischiorectal fossa. And then try to come to conclusion which is the correct option. So the correct option is that the fascia covering the obturator internus is the lateral boundary, because you have to know all the boundaries. Normally they ask about the lateral or the medial boundaries. So if you have a look at this diagram here, you can see that the levator ani, it forms the superior and medial boundary. Medial boundary is formed by the rectum. Then the lateral boundary is the obturator internus muscle, and inferiorly you have the perianal skin. Okay, so you have to know all the boundaries of the ischiorectal fossa. Normally they would ask you the lateral boundary or the medial boundary. So medially you have the rectum and the anal canal, and laterally it is the obturator internus muscle. It is enough if you remember this much about the ischiorectal fossa. Now again coming to something about the nerves. So we know that femoral and obturator nerves, they are part of the lumbar plexus. So what is the nerve root of the obturator nerve? Femoral and obturator, both of them have the same nerve root, L2 to L4. However, there is one important difference, or two important differences you can say. One of them is formed from the anterior rami and one is formed from the posterior rami. So obturator is formed from the anterior rami of L2 to L4 spinal segments, and the femoral comes from the posterior rami of L2 to L4, L2, L3 and L4. Another important difference is where they emerge from the borders of the psoas muscle. So femoral is more laterally. It emerges from the lateral border of the psoas muscle, whereas obturator emerges on the medial boundary of the psoas muscle. Another very direct question asked is about the nerve supply of pyramidalis muscle. So we know this pyramidalis muscle, it is a very small muscle, a triangular shaped muscle which is there below the rectus abdominis. Now the nerve supply to the rectus abdominis, it comes through the intercostal nerves T7 to T12. Pyramidalis is supplied by a specific nerve. It is called as the subcostal nerve, or it is the T12th or the anterior division of the 12th thoracic nerve, which is called as the subcostal nerve. It supplies other branches, it supplies other muscles of the anterior abdominal wall also. So pause the video here and see which are the other muscles that are supplied by the subcostal nerve or the anterior division of the 12th thoracic nerve. Another interesting question. You have this lady, she has ascites, she has undergone a paracentesis, and after the paracentesis it has been found that she has a hematoma. Hematoma is in the iliac fossa on the inferior aspect, and your consultant says that this hematoma that has arisen, it is because of damage or because of trauma to the deep circumflex iliac artery. So the question is, the deep circumflex iliac artery is a branch of which vessel? We know that the trauma that has arisen, it is because of a superficial branch. You have to know all the branches of the internal iliac artery. Okay, so definitely deep circumflex iliac, it is not a branch of the internal iliac artery. Internal pudendal artery, we know it is a branch of internal iliac, so that leaves out the internal iliac. Common iliac is an artery which is much higher up, so you are unlikely to traumatize the common iliac artery. Femoral artery, yes, it is an artery, but the femoral artery, we know it supplies the lower limb, and you are unlikely to damage it whenever you are draining an ascites. So the question left here, obviously, it is only the external iliac artery that is left out, and yes, the deep circumflex iliac artery is a branch of external iliac artery. Okay, so another way to remember that the external iliac artery, once it passes below the inguinal ligament, it is no longer called as the external iliac artery, it is called as the femoral artery. And the deep circumflex iliac artery is a branch that arises before the external iliac, before it passes below the inguinal ligament. Okay, so the only choice that is left there is the deep circumflex iliac artery is a branch of external iliac artery. Many times we have found that in anatomy the questions are like simple questions or even one-liners. So this is another one of that. They are directly asking you which muscles form the pelvic diaphragm. So there is a difference here between the pelvic diaphragm and the pelvic floor. We know that the pelvic floor, it is made up of the pelvic diaphragm and the muscles that form the anterior and posterior urogenital and the posterior triangle. So here you have to know the muscles that form the pelvic diaphragm. They are the deepest muscles of the pelvic floor, and that is the levator ani and the coccygeus. These are the only two muscles that form the pelvic diaphragm. The other muscles that form the anterior and the posterior urogenital diaphragms, these are more superficial muscles and they do not form the pelvic diaphragm. They contribute to the pelvic floor. Another direct question asked is about the blood supply, or where do the ovarian arteries arise. Okay, so one thing you have to know, that ovarian arteries, they are direct branches from the aorta, or it could be gonadal arteries. In general, you can say that gonadal arteries, we know they are direct branches from the abdominal aorta. So the question is, from where do they rise? This is again a knowledge based area, and you have to know that the ovarian arteries or the gonadal or the testicular, they arise at the level of L2. Okay, another question which is very frequently asked, and as students of OBGY, you have to know this question. So you have a multigravid lady who has had all previous vaginal deliveries. She comes to the clinic with history of a lump in the vagina, and after examining her, you realize that she has uterovaginal prolapse. So the obvious question here is, which is the ligament that is likely to be injured to give rise to uterovaginal prolapse? So obviously you have to know the supports of the uterus. Okay, so the options here is round ligament, broad ligament, uterosacral, inguinal ligament, or all of the above. Now We know that round ligament and broad ligament, these are basically just folds of the peritoneum, and they really do not give any support to the uterus. Inguinal ligament, yes, it has no role, or it is not even remotely connected to the uterus. So the only choice that is left behind here is the uterosacral ligament. Okay, so this is a diagram that shows you the supports of the uterus. So you have the uterosacral ligament, which is posterior. Then laterally you have the transverse cervical ligament, also called as cardinal ligament or McEnroe's ligament, and anteriorly you have the pubocervical ligament. These are the only three ligaments that support the uterus. Round ligament and broad ligament really do not have any role in supporting the uterus. Another question, which is something that we are doing every day. So whenever you are doing a lower segment uterine section, lower segment Caesarean section, there is a structure that helps you identify the upper segment from the lower segment, which is this structure. So the options given here are uterosacral ligament, round ligament, utrovesical fold of peritoneum, broad ligament, or the ureters. Ureters, yes, we know they are very deep structures. Unless you open up the posterior peritoneum, you cannot have access to the ureters. So naturally, these ureters, they play no role in helping you understand or differentiating between the upper segment and the lower segment. Uterosacral ligaments, these are located posteriorly. So they have no role in telling you, especially when you are doing a lower segment Caesarean section, as to how to differentiate between the upper segment and the lower segment. Round ligament, it is attached to the upper segment, upper uterine segment, and it comes out laterally from the upper segment. So broad ligament is another fold of peritoneum, but it doesn't help you to distinguish the upper segment from the lower segment. It is only the utrovesical fold of peritoneum, which we know you pick up the loose fold of peritoneum that is there and you incise it open, and then you will get access to the lower uterine segment. So if you have a look at this picture very carefully, we know that the bladder, we know that the peritoneum, it covers the bladder, it goes posteriorly, and then it gets reflected over the uterus. So it is called as the UV fold of peritoneum, and this reflection that takes place, it takes place at the junction between the upper segment and the lower uterine segment. So unless you open the utrovesical fold of peritoneum, you are not going to get access to the lower uterine segment. So it is this utrovesical fold of peritoneum that helps you to distinguish between the upper segment and the lower uterine segment. So these were a few questions that are typically asked in the exam, and I hope they were helpful to you. So thank you once again for watching this video, and I hope you have got an idea of the type of questions that would be asked in anatomy module. Keep watching, stay tuned. We are coming up with RRR series for all the modules. So good luck for your exams. Keep studying, and I hope all of you clear these exams. Good luck once again, and thank you for watching the video. I hope it was helpful to all of you.